You're welcome again. The next update we would like to review with us from the last IAS meeting in Brisbane has to do with the subject on unstructured HIV treatment interruptions and its effect on mortality. Professor Agbaji, have you had anybody asking you whether it's going to remain ever on this antiretroviral drug? Have you ever somebody asking you about drug holiday? Can I take a break, from this medicine for some time? Have you can a number of your patients ask you that question?
Yes, particularly patients that come and they say their viral load is undetectable, I don't have the virus again. Do I need to continue taking this medication? And I let them know that yes, even though the virus is not undetectable, the virus is undetectable, you will still need to continue because it's still there. And if you discontinue, there are consequences for now. I reassure them that they need to continue.
Thank you very much. And that is actually the subject that we want to discuss and let the data speaks. If you discontinue antiviral therapy, what happens? But we must let us know that just a little bit of a knowledge on what is meant by HIV treatment interruptions. There are two categories of HIV treatment interruptions. There's the one that we call analytical treatment interruptions, which is designed as actually a research study, a research endeavor to show that is it possible that if an individual that has met some criteria could be discontinued on antiretroviral therapy or not. And if he or she is deliberately discontinued, how are we going to continue to monitor this individual to decide when are we going to reinstitute, or if there's actually going to be a need to have to restart the therapy. That's what we refer to as analytical treatment interruptions. But there are a number of life situations where an individual that's supposed to be on lifelong antiretroviral therapy may not be able to remain on antiretroviral therapy. If an individual for any reason has to go for surgery, and the surgeon will say you cannot take anything by mouth, and today we do not have antiretroviral therapy available as intravenous therapy, you have to interrupt therapy. Or an individual develop gastroenteritis, or you cannot even tolerate anything that goes there, it comes out. That individual will not be able to take the drug. And some individuals actually developed drug toxicity. As soon as the drug is there, they feel as if, in fact, it's better I drop the rather than continue with this toxicity. Some individuals may not be able. So what is the effect of these unstructured, unplanned, or situation-imposed treatment interruptions on the overall outcome of HIV treatment? And we have some data that was presented from review of big database from South Africa. Dr. H. Muller and his team have this information for us at the last IAS meeting in Brisbane. What they did was to look at the international epidemiology databases to evaluate AIDS in South Africa. And what they did in that was to define what they mean by an individual who has interrupted therapy, and for how long has that individual interrupted therapy. Some individuals started therapy. Within 6 months of starting therapy, they stopped therapy. They define those people as highly treatment interrupters. And they have other group of people that have been on this drug. After some period of years, they are fatigued, they are tired of it, and on their own, they stop therapy. They describe these people as late interrupters. But you are an interrupter only and only if you have stopped taking therapy for more than a period of 6 months from the date that you stopped it. So if you stopped therapy today and the next 5 months you restarted therapy, you are not defined as an interrupter in their data. So from what they did, looking at this category of people, those who they define as having interrupted therapy and those who they define as having not interrupted therapy, and if you are And if your device having interrupted therapy, are you an earlier interrupter or are you a later interrupter? They look into their database. Between 2014 and 2019, a period of 5 years. And what they found out was really, really instructive. Those who, and the data just speak to itself. What they are doing is that if you are an early interrupter, what is the risk of death? If you are a late interrupter, what is the risk of death within that period of time they have studied? If you didn't interrupt therapy at all, what is the risk of death? And this is actually the data that is so instructive. As you can see there, what they found out was that the early interrupters, if you start therapy and within 6 months of starting therapy, you have stopped taking the therapy, and you stopped for more than 6 months, that is, you are an interrupter, the likelihood of death is 2.3 more than likelihood of death if you didn't interrupt therapy. And if you have taken therapy for a longer time before you become an interrupter, the likelihood of death is 1.9 times the likelihood of death than if you never had to. So starting therapy and stopping a lot early is associated with a higher risk of death. Now, they also look at some other metrics. Important metric that they look at was what was your baseline CD4 cell count. Individuals who have a higher CD4 cell count and eventually interrupted therapy, they have a lower risk of death than if you had a baseline CD4 cell count that is low and you happen to interrupt therapy at any point in time, the risk of death is high. The other important finding in that study is that there is a significant correlation between the age of the individual who is an interrupter. If a younger person is an interrupter, the risk of death is a little bit lower than if an elderly person happens to be an interrupter. So this data is so robust because it involves a large database that is involving thousands of HIV-infected patients from South Africa. So your discussion with your patients that although they have achieved pharmacological suppression, that does not mean that they should stop therapy. It's very, very germane. And we have this data from South Africa that is actually discussing that. If you look at this survivor curve, you see that top one, the blue curve there, is the survivor of individual who have never interrupted therapy. That green line is the survivor of the individual who are late interrupters. And of course, the red line there is the survivor curve of individuals who are early interrupters. So the take-home point from the data that was shared by Dr. H. Muller and his team from South Africa is that interruptions to care in HIV treatment are a significant driver of mortality. That's a big take-home point. Therefore, there's a need to retain people in care to prevent mortality. And I think this is very, very instructive. So I hope my colleagues will take a leaf from this. I also get asked these questions. Doctor, will I remain on these drugs forever until a cure is found? The answer is that we have to remain on this drug because discontinued therapy unduly for any reason has been shown from this important data review that it carries a higher risk of death.
It's important that programs are designed and policies within the clinic and in the guidelines to help as much as possible to keep patients in care.
To retain our patients in care. So whatever we are able to do to support retention in care is very key. Thank you.